Good morning and welcome. Thank you for attending today's FASD learning session. My name is Louise Hayes and I'm a member of the Cross Ministry Committee on FASD. Before I introduce our presenter, there are a few housekeeping tips. You can ask questions during the presentation by using the question and answer module on the right-hand side of your screen. A session facilitator is monitoring the questions and will pose them at suitable times during the presentation. If we aren't able to answer all the questions during the live presentation, we will answer them via email after the session is over. It is important that you include your email address when you ask a question, otherwise we have no way to send an answer to you. The presenter's contact information can be found at the back of your handouts and on the final slide of the presentation. In order to receive your certificate of attendance, you must have signed in after 8:50 a.m. Evaluations for this session will be emailed to you after the session. Please fill them out and return them. We rely on your feedback to continually improve what we do and how we do it. Today's presentation and handouts will be posted for viewing and downloading on the CMC website, fasd-cmc.alberta.ca. If you experience any technical issues, please email Clayton at clayton.knoll, Knoll, at teacherstv.ca. Also, please let your local tech support know, as the problem may originate at your end. As Alberta continues to evolve the FASD 10-year strategic plan, education and training continues to be a critical aspect in the plan for all stakeholders, such as individuals living with FASD, their families, caregivers, networks, researchers, policy and program staff, and so forth. This is our 5th year of offering sessions. We are now broadcasting via both webcasting across Canada and video conferencing technology in the North. As always, these sessions are taped and will be available on the CMC website or fasd-cmc.alberta.ca. We are pleased with the ongoing interest and attendance in this initiative. We appreciate the work of CASA, Child, Adolescent and Family Mental Health, Teachers TV, and the Alberta Centre for Child, Family and Community Research in making this initiative a success. Today's session is titled Treating Co-occurring FASD and Conduct Disorders in Youth. We are very fortunate to have Dr. Vinesh Gupta here. Dr. Gupta is currently appointed as an adolescent forensic psychiatrist at Alberta Hospital, Edmonton. In addition, he is also the section head for child and adolescent psychiatry for Edmonton Zone and the director for the Division of Child and Adolescent Psychiatry at the University of Alberta. Before moving to Alberta, he obtained his dual training in child and adolescent psychiatry and forensic psychiatry from the UK. Dr. Gupta also completed a diploma in psychiatry from India before moving to the UK. During his career as an adolescent forensic psychiatrist, he has completed more than 300 reports for youth involved in the criminal justice system and has provided evidence as an expert witness on a number of occasions. Please join me in welcoming Dr. Gupta.
Thank you. Morning, everyone. Probably just say a couple of points, repeat a couple of points that Louis has already made. Feel free to interrupt in between, ask questions. Otherwise, you will probably get bored and want to leave early, so we don't want that, unless you want to do that because of the weather. And also do fill in the feedback forms. If you don't like listening to what I say today, you don't want to listen to me again. And if we don't have the feedback forms, there's no way for these people to kick me out. So make sure you do that. Right. I think I should give some background as to why I am probably doing this presentation. As Luis indicated earlier, I've been working at Alberta Hospital, Edmonton. I've been there for about just under 5 years now. And the population that I deal with there is 12 to 20-year-olds. All the youths that we see there are involved with the criminal justice system. And a huge number of these youth have some form of learning disability. Quite a few of them have issues around FASD. They may not necessarily be diagnosed with FASD, but for various reasons, sometimes we don't have the history that we need to make a confirmed diagnosis of FASD. On other occasions, we don't have the resources to go through a FASD assessment. But if I even look at the current population that we have on the unit where I'm based, probably half the kids have some issues either related to or around FASD. So and on an average, we see about anywhere between 90 to 120 patients every year on the unit. And even if we say maybe half of them, based on various research that have been done around youth who are involved with criminal justice system. So we are talking about in the 4.5 years while I've been around 200, 250 youth who have gone through the unit at Alberta Hospital who have possibly had FASD. Other part of my job is to actually provide mental health consultation services to the Edmonton Young Offender Center as well as the Calgary Young Offender Center. And again, they do get a number of youth with FASD and related mental health issues. So that's kind of the background as to why I am able to talk about FASD and conduct disorder. The other thing that you need to know is this is not a presentation which is based on literature or research. What I'm going to talk about is practical steps that we use as a team on our unit when we are dealing with these youth, and some of the practical steps that we use while we are transitioning them to the community. So this is not going to be a heavily research-loaded presentation. It's completely from our experience of what we do with these youth. And quite a few of the youth that we get are high-profile cases that usually hit the media. So if you hear of any youth under the age of 18 who has committed a serious crime, they do end up coming to our unit for an assessment. Some of them stay back for treatment. So that's the kind of population we deal with. On the other hand, there are youth who have been involved in minor offenses, but do get involved with the criminal justice system on a regular basis, on a repeat basis, and they end up coming to us as well. And we offer treatment and then again look at transition to the community. As part of our service, we also have an outpatient service if you're not familiar with the forensic services available for youth. So the Turning Point program is the inpatient unit where I'm based, while our outpatient clinic is called the Center Point, which is based downtown, not far from here. And quite a few of these youth that are discharged from our services do end up being seen, followed up by therapists or psychiatrists from Centerpoint. So if you need any more information about either of these programs, again, you can email and we will try and get you the information or any other resources that we may have information on. Right, so that's kind of the background. And as I said, please feel free to interrupt, send questions, and I'll be more than happy to answer them in between as well. So the session goals for today. I think people who work with youth with FASD and conduct disorder are aware that every individual youth who presents to you has different needs. So what we can't really do is come up with a specific plan or a program for these youth as a group and then try and implement it. We have to try and identify the individual needs of each and every youth before we can say this is what is going to work. And I'll base my presentation around some of the youths that we have dealt with on the unit. So if I just think of some of the youths that we have dealt with off the top of my head, there's one youth that we recently discharged who's now 19, who's been charged with several serious violent offenses, has an IQ of about mid-80s, has a speech impediment, uses drugs, alcohol, has questionable family support. So he has needs around his speech therapy. He has needs around drugs and alcohol abuse. He has needs around his aggressive behaviors. He's also quite impulsive. So he probably needs, or rather he did require treatment with stimulants to help him deal with his impulsivity. While another one, if I think about, is a girl who was with us towards the end of last year. She had just turned 18, had been charged with an assault. This girl had been with us for about 2 weeks, and that's about it. She stayed with us for 2 weeks, and then she was released. I distinctly remember her because she was probably one of the lowest functioning kids we have had on the unit. She could not formulate even a single sentence comprising of more than 2 or 3 words. We do all the investigations and we find out the girl is pregnant. She had no clue that she was pregnant. This was already her second pregnancy. She came from way up north. I think she might have been from Demery or somewhere like that. I can't remember where exactly she was from. So imagine trying to get information about somebody like that. We somehow managed to get hold of one worker who told us that this girl basically gets high on all sorts of drugs that are offered to her by various people. And a few days prior to her arrest, she had been running around naked, was engaged in sex with multiple people, and she had no clue what was going on with her life. So this is another girl with FASD. So, and that's the kind of differences in profile we are talking about. A third one is another FASD guy who's again very low functioning, probably an IQ in 50s. He was very recently admitted with us, and he's been charged with 10 sexual assaults. I'm not even sure if this guy is aware of what's going on, whether he's even fit to appear in court, whether he's even fit to plead. So all these 3 youth have different needs. What you cannot do is come up with a program that will cater to youth with FASD and conduct disorder, because they have all very different needs. If you look at the girl, she probably needs more care and nurturing to keep her safe. And in the process, she probably ends up hitting people when she doesn't know what's happening with her. While the first lad that I spoke about, who's been charged with several violent offenses, what he needs is basically a place where he's settled, has low stimulus, a job to keep him out of trouble from using drugs or alcohol, not to go to the areas where he's going to get into these fights. The third one we are talking about probably doesn't have any clue about sexual boundaries. He doesn't know what's appropriate or what's inappropriate, whether touching somebody is inappropriate or not. It's quite possible he has himself been sexually abused. He's only 14. So to sexually assault people over a period of time on so many occasions, it's questionable. My first impression would be he's probably himself been sexually abused. But then there are some common features in all of these youth. Probably, I would say 90% of them have come from broken families, have absolutely no clue where their moms or dads are. And again, when I'm giving you figures, I'm not giving you figures from literature or research. I'm giving you figures based on what we see on our unit. So it's very rare for us to get to know the families. We might kind of interview single mother or a single dad, or in some cases a stepdad who has decided to look after these kids, or an extended family members. But more often than not, it's child and family services workers. And they haven't known the youth for long, because obviously they keep on changing as well. But again, that's a reflection of how their needs could be different based on where they are living. What is their legal status? What is their welfare status? Whether they are under the care of child welfare services, or whether they are living with their parents, or are they living with extended family member or friends. Which then leads us to the next goal, which is examining the risk, which again gets influenced by what is it that they are presenting with. So the risk in the first lad is that he's actually likely to harm others by physically assaulting them, while in the second lad is that he's likely to assault others by sexually assaulting them. And what's also interesting about this second one is the Child and Family Services actually, it seems, have attempted to provide special placements for him. And he was being looked after on a one-to-one basis, 24/7, by a male staff member. And this guy actually ends up sexually assaulting that male staff member as well. So then the Child and Family Services decide to change it to 2 male staff members 24/7. So the guy ends up sexually assaulting one of them again while one is sleeping. So the risk is changing there continuously. And you don't know what is resulting in that change of risk. So the previous sexual assaults have all been against his sister, who's younger than him, about 3 or 4 years younger than him. So one would assume that is the risk. The risk is against young girls. So it's okay to provide supervision with an older male. But then the risk suddenly changes where he sexually assaults the older male. So you change it to being supervised by 2 males. So you can't even have a male who's sleeping and the other one is supervising him. So it's very important to identify the risks and keep on monitoring that risk. It can change. It can change fairly quickly. It can change with the placement. So if there is a youth who has been in a secure setting, his risk is hopefully going to be lower. But if they were to be released or discharged in the community, the risk would suddenly go high. And it will depend on what kind of support do they have in the community. So again, it's important to be aware of that. And then obviously the role of multiple agencies, cross-ministerial approach is required when we are managing any of these youth. There is no way that just healthcare or just child welfare services or a voluntary organization, none of the agencies by themselves can provide much as far as attempts at reducing risk are concerned. It has to be a joint venture. There is no way, if I was to say as forensic services, we can reduce the risk of the youth and we don't need anybody else, then I don't know what I'm doing. It's as simple as that. You should not trust me if that is what I'm telling you. So if there's any agency, any worker who's saying that they can reduce the risk by working on their own, then they have no clue what they're dealing with, then they don't know what they are doing. So I would be looking at their abilities, their understanding of the risk, their understanding of what kind of deficiencies these youth are presenting with. If there's one thing you can take from this session today is whatever you do with these youth, be consistent. If they get different messages from different people, it is not going to work. It is just not going to work. And if they're being sent to the same environment that they came from, again, we are setting them up for failure right away. So if these 2 things, if we can remember just these 2 things and nothing else, that's okay. You can probably go off to sleep for the rest of the session now. But I'll give you an example of what I mean by consistency. And it was quite interesting, very simple. We had, this was around Halloween celebrations. So we do have Halloween celebrations on our unit because most of them are still youth. They're 13, 14, 15, 16-year-olds. But on the other hand, we have quite a few of those who have been charged with either a murder, attempted murder, or armed robberies and stuff like that. So these are people who have been involved with violence and aggression quite a lot. So there were some staff members who decided to let the youth decide what is it that they wanted to make or do for Halloween. And a couple of them decided to make a haunted house, so which was fine. To take it further, you start seeing the creativity, and so they added some ghosts on it, which is okay. Then it became some handprints which were stained in blood. So then there is fake blood dripping, so all sorts of red color was used for that. And on Halloween itself, one of them decided to just use a white bed sheet as kind of a dress, and covered it in red paint to kind of show it as blood. So, but it looked quite gory. That's the only way of describing it. So now a couple of staff members got upset with him that, look, you have been charged with a serious violent offense. You have stabbed at least 3, maybe 4 people. So this is inappropriate that you're wandering around with something like this. And I kind of ended up coming into all this conversation or celebrations or whatever you want to call it towards the tail end of it. Now I'm sitting there and thinking that this guy has been told it's okay to make a haunted house with blood fingerprints or blood-stained prints on a haunted house, but then he's being told it's not okay to have a bed sheet that is covered in red paint because it's too much. Somebody who has got FASD will have difficulty differentiating between those two things. If it's okay to use red paint to show blood on a haunted house, then it's okay to use it on the bed sheet. They don't see the difference between the two. So what we were clearly doing here was giving him an inconsistent message. So we are saying it's okay to do it in one scenario, but it's not okay to do it in another one. He doesn't understand the difference between the quantity of the blood that is being used. It doesn't really matter to him whether it's half a pint or 3 pints of blood. For him, blood is blood, and if he has been allowed to use it in one place, he cannot understand why he cannot use it in another place. And in normal circumstances, when we are outside in the community, we have kids, it's okay. They might be able to understand some of those differences. But this guy had significant problems understanding where is the difference. And we forget that. We generally expect that they would be able to understand those subtle minor differences, but they don't. And that's where it is important to have clear, consistent messages. Because the other problem is that they all have, most of them have, I won't say all, language difficulties, and they're mainly around comprehension. So if they're not getting clear, simple messages, they won't be able to understand what is being expected or what is being said. So that is why consistency is very important. And environment. I'll probably talk about the same youth who was charged with several stabbing incidents. So he had been with us for almost an year, 18 months. And we started working at the process of transition back to the community. Quite settled on the unit, almost a role model. And then we start taking him out, and some of the outings, as you can see, probably most of you who work with voluntary organizations, with mental health services, are located in downtown area where the crime rates kind of are just as high as possible within the city. So he had appointments with addictions counselor. He was supposed to see an individual therapist, and he's taken out, and all of it is in areas where he used to hang around just prior to his offenses, and some of his offenses were committed in those areas. We start taking him out to for various appointments, and The guy who had been very settled on the unit goes back to the same environment and starts getting anxious right away. So you are taking him back to an environment where he committed all the offenses. All his memories are hanging out with his peers, using drugs, using alcohol, getting into fights, and he has no clue what to do there. So if the environment is not changed, what we are doing is we are sending him back to where he was, just to do what he was supposed to do. So that's where these two are very important things when we are looking at any kind of changes, rehabilitation of these youth. One of the things we like to do is when a youth is referred to us, obviously, as I said, I work on a unit which is where we get youth only from criminal justice system. But at the same time, it's important to try and identify what resulted in a referral to whatever service they are coming to. So most of you are probably based in the community, and you will get some youth who's referred to you following an incident, following difficulties at school. They may start truanting, they may start having increasing behavioral problems, whether that's at school, whether that's at home, or their living environment might change. So they're probably taken into care, removed from the care of their family, parents got divorced, somebody passed away in the family, so they don't have a carer who has been around for a while. Or they may have attempted to harm themselves or others, which is, again, not unusual with youth with FASD. There may have been a history of recent neglect or abuse, which might have escalated because quite a few of these youth come from a background where they have been subjected to one or the other form of abuse. So what you need to remember is not all youth who have been diagnosed with FASD do offend. So not everyone gets diagnosed with conduct disorder. Not everyone gets into trouble with the criminal justice system. Most of the youth with FASD who do get into trouble with criminal justice system would have had some history of being abused themselves, or having been in an environment where there is significant use of alcohol, drugs, or they're being looked after by carers who have themselves been in trouble with the police. Or they have lack of supervision, they have no appropriate carers who are providing them the right kind of role models. So it's important to identify what is it that led them to where they are at this stage. Because they usually, by the time they're diagnosed with these things, they would have probably gone through a number of assessments, would have been seen by a large number of professionals, and they just keep on going through the system. What you also need to remember is, if you are working with criminal justice system, so if you're a probation officer, or if you work with the Youth Criminal Defense Office, or you work within the youth criminal justice system, then you will not have a youth who can be referred to you before they are 12, because that is the minimum age of criminal responsibility in Canada. So in some cases, you may find they are already known to various services, but the only reason they don't come to you till they are 12 is because it's only at that age that they can be found criminally responsible. So what you are just seeing is a change in their legal status at that time. So they may have had those ongoing behavioral problems for a while, but they could not really be kind of held responsible for those issues legally till they turn 12. So that's another thing you need to be aware of. And then obviously with large number of these youth using drugs and alcohol, quite a few of them end up coming up with emerging mental illness. It's not unusual for a number of these youths to end up in emergencies around the province with intoxication, being found by the roadside because they were high on something, or they were psychotic, or they were getting agitated, aggressive, or they have tried to harm themselves while they were under the effect of alcohol or drugs. So it could be any of these reasons which might lead them to be referred to whichever services you work with. The reason we need to identify the crisis is we might believe that there are a number of other issues that are involved that need to be dealt with. But what is important is to look at it from the youth's perspective as well. Unless they buy into it, unless the youth buys into whatever you're trying to do, it's not going to work. And I actually had an interesting conversation with one of the youths yesterday who's not FASD, but that gives you some idea why I'm talking about this. So we have been having the significant trouble with this youth to get him engaged into education. And he doesn't believe that he needs the level of education that we are proposing for him to get where he wants to be as far as his career choices are concerned. So as a team, we discuss a plan and we decide we are going to share it with the youth and see what he feels about it. So as soon as I describe the plan to him and say, so what do you think about this? And his response was, I guess it's your plan. So right away what he's telling us is, no, I don't like it, and it's not my plan, so I'm not going to get engaged into this. So unless you can get the youth to buy into that plan, it is not going to work. It's as simple as that. And if they see that there is something that is a crisis based on what they view as a crisis, and if we ignore that, it's not going to work as well. They are not going to work on the priorities that you identify. They would work on the priorities that they identify as important for them. So you may want to work around those priorities. You may want to help them change those priorities. But at the time when they're in a crisis, that is what their priority is. So you have to identify that. You have to somehow calm them down, settle that down, deal with that crisis if you are going to make any progress anywhere at all. So it could be that they have just been kicked out of the house because mom doesn't want them. She's had enough with John or whosoever it is. Or the school has decided to kick them out. So it's interesting when that happens at school though. So when school kicks somebody out, we as professionals think that the priority is to get them back to a learning environment, to get them back to a school. They may not see it as that. They may have deliberately done something to be kicked out of the school because they're finding the coursework very difficult. So for them, the crisis is not being kicked out of the school. The crisis would be going back to school. So which is exactly the opposite of what we might identify as professionals. So again, it's important to understand the ABC of the crisis. So the antecedents, what led to the crisis and what was the consequence of that. So it's very important to look at that. And quite a few of those situations would be around family and carers. As I've indicated, there's usually a huge history of abuse, neglect. Quite a few of these youth come from environments where substance misuse is very common. Another girl that we probably have had her at the hospital now, I think 4 or maybe 5 times. I've been around at the hospital just under 5 years, so she's probably been admitted once almost every year. This is a girl who comes from a family where the family home is actually identified as the local drug house. So all that happens in the family home is parties all the time. According to what we are told is mom is drunk most of the time. There are strangers who are going in and out of the family home. Doesn't matter whatever time you go in. So this girl also has a younger sister, and in the past she's been quite concerned about her younger sister, who also has some FASD features. So her concern has consistently been that my sister would end up turning up like me. So this girl has been involved with the criminal justice system. he has a long history of harming herself, ends up assaulting people in various residential group homes, and then ends up harming herself, takes overdoses, and goes through that cycle repeatedly and keeps on coming back to us. And she does that every time she goes back home. So she's home sometimes for a day or two, sometimes for a week, and I have not known her to stay at her family home longer than a few weeks. She absconds within a matter of a few weeks. So what we are essentially doing here is we take her out, we stabilize her in the hospital, and then send her back. So the next time she's probably going to refuse to come to the hospital at all. So we are not really doing anything for her. If anything, we are repeatedly traumatizing her. So we are the adults who are supposed to keep her safe. We are the adults who are supposed to ensure that she doesn't go through the same situation again and again. But we are the ones who are sending her back again and again. And this is a good example of where if multiple agencies are not able to work together, that is what happens. So somehow we are not able to work together well with Child and Family Services. So we do our bit, and then we try and advise the other agencies to find alternative placement, but somehow it has never worked. So what we are simply doing is, okay, we'll look after you, we bring you in, almost babysit her. That's how I would see it, because we are not making any long-term changes in this girl's life. What we are doing is we are keeping him safe for 2 months, 3 months, 4 months. Probably the longest we have had her is 6, 7 months, 8 months. And then we are saying, it's okay, you can go back there. Doesn't matter, nothing has changed there. Doesn't help. So she's back to where she was. And that's where the big problem is. That's why I started talking about environment. So, and that is a very important issue that needs to be dealt with. If we are going to send somebody back or send somebody to an environment where it is going to continue to be abusive, all the good work that might have been done is a waste of time and money. It's not going to have any effect on anything at all. Similarly, violence, it's the similar kind of thing. Start talking to them about trauma, start talking to them about abuse, and then send them back to the same environment without making any changes. Doesn't do anything. So the message, again, we are giving to them is, it's okay to be beaten up. It's okay for your mom and dad or your mom to be beaten up by a new guy who's in the house every 6 months or every year or every 2 years, and then walk out. So that's the message we are giving to them. So there's nothing wrong with going back to that environment. Lack of supervision, which kind of, again, brings me back to the girl who just turned 18, had absolutely no supervision, was getting high on drugs, was having sex with multiple partners, had no clue what was going on, had absolutely no supervision, nobody to look after her. So there were agencies that were involved with her. Her first kid was removed as soon as the baby was born. But then what? She's again left to her own devices. So by the time she's 28, she would have probably given birth to 5, 6, 7 kids. And they'll all be in care. But nothing has been changed for her. And she'll probably keep on assaulting people when she's being forced to have sex, when she's being sexually assaulted, when she's being raped. So she will keep on coming back to the system as well. So those are the kind of things that we need to remember when we are dealing with these youth. And quite a few of these youth have no role models. Their role models are people who have themselves been in jail, who have themselves got a long history of using drugs and alcohol. So that's the kind of role models they have. I had another youth recently at the hospital who's just turned 17, started getting involved with antisocial peer group in about, I think, just over 6 months, not long. So what turns out is that there has been a recent addition to the family. A nephew of the mom moved into the family home, about 20 years old, 21 years old. He's got strong affiliations with gangs, uses alcohol, drugs, is involved in selling drugs, has access to weapons. And our guy, who's FASD, has very few friends, generally isolated, has little social interactions. And he suddenly finds this role model who's willing to take him out with him, involve him in things. So in 6 months of this guy moving into the family home, our guy is already getting into a lot of trouble with the police. He's been arrested for an assault, possession of weapon. So that's the role model he has. But then interestingly, turns out when you start talking to him, he's been well taught by his parents. So he comes in, no family history of drugs, alcohol, nothing, except he agrees that this cousin has problems and he started following this cousin. Whenever possible, we try and interview the families if they do turn up, whether face-to-face or on telephone. And believe me, that's the most important thing that you can do when you're doing an assessment or you're looking at any form of planning as far as treatment or rehabilitation is concerned. You have to talk to the family members. There's absolutely no excuse to not doing that. It gives you so much insight into what's going on in their lives. So we managed to talk to this mom who comes in and she says the same thing, no drugs, no alcohol, nothing. And I ended up talking to her and saying, look, I've got information which is contrary to what you are saying. And I'm kind of concerned with what you're telling me. She gets really angry with me and kind of just leaves the interview halfway through because obviously there were things that she was telling us were not really the truth. So next day I sit down and talk to this youth again. And mom has already called him and told him that your doctor has told me I'm a liar and you don't have any need to talk to him. And the guy is very angry. But what it does for me is while he's angry, obviously he becomes a bit disinhibited in the way he's interacting with me. And he ends up blurting out that, yeah, mom smokes weed, but only once in a while, maybe a joint a day. And yes, dad has been in trouble with police. Till that time, nothing was wrong with the family. And then I end up talking to his defense lawyer who tells me that he's known the dad for 20 years now because of all the trouble he has been in with the police. So those are the role models. So there's one role model who is taking him out, helping him associate with peers, kind of making him socially acceptable, because most of these youth are isolated. They have no social skills to make friends or maintain friendships. Helping him use drugs. Second role model is mom, who's herself using drugs and alcohol at home, but also telling him to lie. Third role model is dad, who has been charged, who has various charges over the previous 20 years, has been to the prison on a number of occasions. He had some assault charges as well. There's domestic violence. So that's the kind of role models they have. So a lot of these things are normalized for them. So it is normal to engage in physical violence. It is acceptable. So when we are trying to change something, what we are looking at is trying to change that they think is normal. I'm pretty sure a number of times, I've had this, and I'm sure lots of you have had this experience where the youth will actually ask me, so you're telling me you have never been jumped upon? How is that possible? So you're telling me you have never carried a knife? It's normal, everyone carries a knife. What's wrong with you? So that gives you an idea what is normal behavior for them, what is normal expectation for them. So it's okay to carry a knife, it's okay to be jumped upon, because that is what is normal for everyone. So they don't understand that those are not normal things. They don't expect them not to happen to everyone else. So and when we look at these families, carers, role models, A number of times we end up in situation where we have to look at whether this is somebody who needs alternative accommodation. Again, it brings us back to environment as well. And it's never easy to do that. That's probably one of the most difficult things to deal with when we are dealing with this youth. Finding a placement which we consider as appropriate. I have no idea how much time do I spend just with this aspect of rehabilitation. And if there are people from Child and Family Services listening to this, I have no idea how many of them I have actually ticked off in a manner that they might be really angry with me, because accommodation is a huge thing. Placement is a huge thing for these youth. If we are sending them to placements which are not going to keep them safe, which are not going to keep them away from the peer group that they were involving with drugs, with alcohol, if they don't have the right kind of support, it's useless. As I was mentioning about this young girl. So she's going back to the same environment. What have we changed? Nothing. And she keeps on going back to the same thing, doing the same things again. So what we are basically doing is, we are not just failing the youth that we are dealing with. We are actually increasing the risk to the youth by others, as well as to others by the youth. And we are still resulting in a huge cost to the society as well as the victims of their offenses. So we haven't changed anything. We might have changed things in the very short term. They might be okay for the next couple of days. They might be okay for the next 2 weeks. But then we are back to square one. So if we can't change their environment, if we can't provide them with the right kind of support in that environment, then all the efforts that we are putting in is a waste of time and money. It's no use doing any of that stuff. These are things that we would anyway look for most of the families that come into contact with issues around kids or youth in the family, or if they're having relationship issues. So family therapy. And there are a number of times when I've wondered, when I've thought about family therapies with these youths. It's interesting experience to try and go through family therapy with them. So this girl that I've been mentioning, where her house was called the local drug house, I get to meet her mom. And I had spoken to her over the phone, maybe on a few occasions before I finally got to meet her. And I'd always thought, based on the information we had, she's intoxicated or she's high, every time I spoke to her over the phone. And then she ends up coming to see me once. And the first thing that comes to my head is, she's probably FASD as well. So it's quite possible when she was talking to me over the phone that she was high, but at the same time, she has her own difficulties because she's low functioning, because she's herself got FASD. So now you're left with a situation where not only do you have a youth who has got FASD, but she's being looked after by a mother, single mother, who has herself got FASD, has a partner who's aggressive towards her, has another daughter who has got FASD. So I'm not sure how many of us feel comfortable working with that kind of a family where we can provide everything that they need. So I'm sure we all do. We all try to do that. And if we are working in inner city areas, if we deal with these kind of youth, that's what we all do. But how much of a change can we make without engaging the entire family in this scenario? And what kind of family therapy can you really do? What are you going to tell them? Stop using alcohol and drugs? But then what? They're still living in the same house. They've still got the same friends who are still going to come back next day, next night. So you could provide family therapy, you could help the youth, but you cannot change the environment. So we are still left with the same situation. So the point, you will see that I keep on coming back to the fact that you can do one thing, but if you don't do the second thing, or if you don't do the third thing, or if you don't do the fourth thing, nothing is going to change. So change in one thing is not going to result in change which is required. So any of these situations, any of these circumstances, any of these issues, if they remain the same, we are going to keep on going back to the same problem. Doesn't matter whatever it is. So we could provide family therapy once we have already worked with the youth. But then what? The environment has not changed, but we still need to do that. And that's where then you start looking at what else is needed. So the other guy that we talked about, I was talking about the one who was charged with several violent offenses where he had stabbed 3 or 4 people. We kind of started looking at what are the changes we need to make. So what we did with this guy was we provided the treatment or therapy as it was needed at the hospital. We started looking at transition. We realized he cannot go back to the same environment. We tried to engage the family. The family in this case is a stepdad and his wife and his children. So this is not even his kind of immediate family in some ways. His mom is known to use drugs, is homeless, is a prostitute within Edmonton. So this guy knows that mom is around, but has had next to no contact with her for quite a while. The stepdad, we start engaging him in family therapy, and he starts talking about his own problems. So now you're suddenly thinking, were we going to do family therapy which was centered around the youth? Or do we need to deal with the problems of this adult now? And do we have the resources to do that? So it turns out he was himself a victim of the residential school system, quite vocal about it. Not vocal in the sense complaining about it, but obviously upset, angry, and had huge resistance around getting involved with health services, child welfare services, because of his experiences. He himself has a past history of alcohol and drug abuse, even though he's sobered up. Is struggling in his relationship with his current wife, has another daughter who has got FASD, and wife is pregnant. So we tried family therapy. We tried to engage the family. But the sessions always turned around talking about him rather than being able to talk about the youth. So we slowly realized going back to the same environment for this youth is not going to work, even though he wanted to go back there. It was a different issue eventually that we were kind of helped by the fact that the family decided to move way up north and our youth did not want to go there. So it kind of sorted itself out. But in this case, then we started looking at alternative accommodation. So what we did with him was, and which is probably true for most of the FASD youth who have been involved with criminal justice system, is they have number of appointments to go to. They have probation officers that they need to go meet with. They have to go and attend their court appointments. They have conditions. They usually don't remember those things. They have no clue what does the order from the court says. It is written in such complex language. Half of the time they can't even read simple English, leave aside being able to read that complex language and then make sense out of it. So we engaged him with a youth worker whose primary role was to take him around to various services or various appointments. Locally, we got him engaged with is it McDaniel project that deals with youth with FASD? Yes. So he has a youth worker from McDaniel project. One of the interesting things we found with a couple of our youth, especially of native origin, was involving an elder, and especially if they ended up forming a good relationship with the elder. One of them started looking at the Sundance ceremony. And I must say I'm not very familiar with that, but what I learned was part of that is that people who are involved in that ceremony are expected to abstain from alcohol and drugs. And I think it's for a period of 4 years or something. And they have to follow some kind of a strict regime of sweats and all sorts of stuff. So this youth, of his own accord, after speaking to the elder on several occasions, decided that is what he wanted to do. And there could have been nothing better than that. Similarly, there was another youth we had, and this was not FASD youth, but he was, I think he was Jehovah's Witness. He was slightly low functioning, but not FASD, and he decided that he wanted to have the priest from his local church. And part of that was, again, that he was going to work with the church on weekends, attend the youth church group every weekend. So what that did was give him something to do over the weekends in the evenings, rather than going out and getting involved with people who are getting into trouble using alcohol, drugs again. So sometimes that works. It does help, especially if the youth is willing to speak to somebody like that. And obviously then we shouldn't forget that a large number of these youth come from group homes. The big problem or the big issue with group homes is that a large number of staff there are transient staff who move on very frequently. They have very little information or knowledge about working with people with mental illness. So if we can't train that staff, if we can't train the staff of these group homes or residential placements to specifically understand the issues that these youth face, sending them to these placements is not going to help. So quite a few of youth with FASD don't remember things. A simple example is, again, going back to this guy who was charged with several assaults. We actually, after doing an IQ assessment with him, we went through the results with him. At length, the psychologist and the occupational therapist sat down with him to look at what are your abilities, what is it that you can possibly achieve as far as education is concerned, and what would be realistic career plans based on that. And this guy's IQ wasn't too bad. It was 84, 85, something like that. And believe me, if not more, about 60% of the youth who end up staying with us for treatment, they all initially want to be a psychologist or a psychiatrist. I have no clue what's wrong with them, but that's what they want to do. So this guy was hell-bent on wanting to become a psychologist. So we kind of, the psychologist and the occupational therapist sat down with him, told him, look, based on your abilities, that may not be a good idea. Went through everything, and he agreed, yeah, I need to look at an alternative job option. So they go through, do that. In less than 3 weeks' time, he comes back and says, so what do you think I should do as my career for my job? Do you remember we went through this? What are you talking about? I don't remember doing that. So he had no clue that, or he had no memory of going through that testing, going through that whole process where everything was discussed, and he had agreed to do go down a different path as far as his career options were concerned. So it's important to be aware, to understand what are the deficits that they might be experiencing. And if the staff who work with these youth are not aware of those deficits, then they're likely to see it as antisocial behavior. They're likely to see it as behavioral manipulation, which is then going to lead to increased friction between staff as well as the youth. And you cannot really plan anything for future or for dealing with them on a day-to-day basis unless you're aware of these issues. What we have also learned practically is that it's always beneficial to try and identify one or two key staff members who can work with the youth. What you need to remember is that they have had difficulties throughout their life with placements, with moving around. We have had youth in the past, by the time they're 15, they have gone through 80 different placements. So even as adults who have, hopefully all of us have had normal brain development, we find it difficult when we have to move or we have to change places. If we look at life events, change of residential placement is one of the top 5 life stressors that can lead to adjustment issues, mental illness. So there are very few that kind of are as stressful a life event as a change in residential placement is concerned. So when we are talking about these youth who have gone through 5, 10, 15, 20, 25 placements, you can imagine how stressful it is for them. But what is also important to understand as a result of that is they have never had an opportunity to form any kind of relationships. Never. They cannot trust anybody. So we had another youth who was charged with a murder. Now, this youth, he would come in, he would sit in the room with the therapist, just would not talk. Doesn't. And I'm pretty sure a number of you who work with this population have heard very often, why should I tell you this? Because I'll tell you this and then you will move on to another job, or I'll be moved to another placement in 3 months' time. So what's the fun of telling you anything? You're a stranger. I don't trust you. Why do I tell my problems to you? And unfortunately, a number of them then get labeled as being uncooperative, not willing to engage in treatment or therapy. What we fail to understand is that it is based on their experience, where they may have tried to do that, but that the therapist only lasted 2 months or 3 months.
One question I've had come in is, I'll just read it. This is from Marge in Regina. She says, I have often read that very young children on the FA spectrum are sexually inappropriate at very young ages, 5 or 6. Does this mean that they themselves are being sexually abused? Or how else might they know about sexual touching at such a young age?
Yeah, see, there are 2 ways of looking at it. Yes, the first doubt that comes into the head is, are they being sexually abused themselves? But what people generally tend to forget is normal developmental stages. So when we talk about kids who are 3, 4, 5, 6-year-olds, a lot of exploration is by touching. And if we are talking about somebody who has FASD, they are probably kids who have got communication difficulties. They don't necessarily understand issues around boundaries. So it is quite possible that part of it is maybe they have been sexually abused, or the other thing to remember is that they may not actually be aware that this is wrong because they don't understand the social boundaries. So they may not have any kind of sexual inclination themselves when they are going out touching somebody. So they may not understand that to go and touch somebody is actually results in some kind of sexually inappropriate behavior. And I'll probably give an example of a much older youth that we have. He is going to turn 16 soon. So his way of communicating with people is he'll actually mimic them. He'll do what they do. Or he'll make strange noises to attract your attention. Or he goes and touches people. And he doesn't see that touching anybody is wrong. He doesn't see it as necessarily being sexually inappropriate. So I think the first thing to do is to understand whether when a 5 or 6 year old is touching somebody, are they actually touching in a manner that would be considered sexually inappropriate? And if it is, then yes, there needs to be further exploration as to whether they might have been sexually abused themselves. So there is no kind of right or wrong way of looking at it. I think it's about exploring all possibilities there, rather than saying it means yes, they have been sexually abused, or it doesn't mean they have been sexually abused. So it could be either. So coming back to where we were about lack of trust. And again, it's interesting. It's actually good that this question came up at this time. A lot of these youth have been physically, sexually, emotionally abused. And a lot of them don't know what is appropriate personal boundary, what is appropriate personal space, what is appropriate social interaction. And with this specific youth that I was just talking about, what's happened is he's been, again, I think this is his 3rd admission with us now. He's been with us this is the longest admission that he has had with us. I think he came to us in February. And every time he came to us, the biggest concern was his sexually inappropriate behaviors. And to make things worse, he has been charged with a couple of sexual assault. Was it sexual interference or assault? I can't remember right now. So everybody's obviously all hyped up. Oh, this is a sexual offender, so we have to be careful. But slowly, as he has stayed with us over the last 6 to 8 months, we have realized when he comes to one of the staff members, and when he's very close, or when he touches a staff member, he's not necessarily doing it because he's trying to be sexually inappropriate with them. He actually doesn't know what is an appropriate way of attracting their attention. He has no clue. So his way of doing it is either make a strange noise, he'll grunt, or he'll mimic you, he'll repeat what you're doing, or he'll actually come to you and touch you. And that's the only way he knows how to interact. So one of the things that we have tried to do is very simple. So we have got slides of people that there is a male or a female sitting here. You walk to this person and you touch them. So the picture is actually showing the male touching the female. And then there is a speech bubble, not right, because she's a stranger. So, but those are the things that one needs to be aware of, that these kids may not know that it is wrong. On the other hand, we had another youth whose IQ was probably in 50s. He's been charged with a sexual assault. Turns out, again, he has no peer group, no friends. Goes in a group home, is with 2 other kids who are slightly higher functioning than he is. Call another 4th one and say, let's play a game. So as a game, they start doing some kind of sexual activity. This guy just plays along. He has no idea. He wants to be part of everything. At some stage, this 4th kid wants them to stop. This guy has absolutely no understanding that the game has stopped now. He just carries on. So it's also about the context as well. What's going on? Where to stop? He doesn't know what is a consent. He doesn't know what's a consensual relationship. He doesn't know when somebody says no, it means a no. He has to be taught. And sometimes you may not be able to teach it. And that's the other important thing. Try to understand, try to recognize your limitations. You cannot change everything. There may be some behaviors, there may be some illnesses, there may be some aspects of their interactions that you cannot change. And again, that's where environment becomes important. So what you can though do is try and change the environment. So try and understand what is a place, what kind of placement will ensure his safety and the safety of others. So what kind of staff can ensure that, yes, he continues to interact with youth, but in a manner that he's not posing a risk to everybody else. So again, environment, carers, management of behaviors, everything comes in at the same time. So you cannot do one or the other thing.
I have a couple other questions we
Yes.
can answer. So here's one from Diane. She asks, you spoke about normalized behaviors. Do you believe that it is important to have conversations with youth to enforce that a particular behavior is not normal, which enforces to them that their very own families might not be normal?
Okay, yes, we need to have that conversation, but at the same time, I think I would like to change the language there. It's not really enforcing it. It's about helping them understand what is not normal. And yes, part of that is making them understand that some of the things that they are seeing within their family is not normal. So it is not normal to be drunk all the time. It's not normal to be high all the time. It's not normal to have a home that is recognized as the local drug house. And we do have those conversations with our youth. So if I look back to this girl whose house was identified as the drug house, we had a number of conversations with her because the expectation was I'll just step back. So while the mom was engaged in using drugs and alcohol, our girl was expected to, our girl was expected to look after the younger siblings, and that's not normal. And that's where our conversations were. So it's not normal for your mom to be under the effect of drugs or alcohol all the time, to have strangers going in and out of the family all the time, and then expecting a 15-year-old to look after 10, 11, 12-year-olds all the time. So it is important. Otherwise, how are you going to bring about the change? So you said a couple of questions.
Yeah, one more. This is from Judy in Whiskey Creek, and she's a foster mother. My foster son, who is 17, does not want to go out into the community to do things with workers. He has been with me for 6 years and homeschooled in our very quiet location. He is no longer in trouble, but workers are really worried that he is not socializing enough. He is lonely, but he refuses to go out with them. He does go out 2 to 3 times a week with me and goes to all his appointments with me. How would you help him with loneliness and workers that he does not trust?
Oh, that would be difficult. I think one of the things that probably one could look at is when he's going out with mom. First of all, it's important to have a consistent worker. So if there are 2 or 3 or 4 people coming in, and if they have changed every 3 months, 6 months, it is not going to help. There is no way that this youth will be able to form any kind of relationships with these workers and be able to go out and do anything. A couple of things that might be helpful. I don't know whether they would or they won't. But first is to try and see if the foster mom obviously feels that she has a good relationship with him, sit down with him and see if there are any activities that he may want to do. So the first and most important thing is to have a plan, but a plan that is his rather than that of the mom or the workers. So what is not going to help is workers coming in and saying, let's go and do this today. He may not want to do it. So maybe try and identify activities that he wants to do or he may want to do. And there are people who are shy by nature. So, and with FASD, it is all the more likely that they may not want to interact with people. He may be interested in some kind of solitary activities. So, but it's about identifying those activities. The second step might be then, when mom goes out with him, If there is going to be a worker who's going to be involved with him for a period of time, then that's the time when the worker should go out as well. So the initial few outings should be with mom, not without the mom right away. He has to start feeling comfortable with this worker. He's not going to start feeling comfortable with a worker who comes in once or twice and then say, let's go out. He'll have significant difficulties trying to trust this person. So this might work, this may not work, but I think those are the basic things. That's what we do with some of our youths that we are trying to transition in the community. If we are going to get a youth worker or a therapist involved, we actually start calling them on the unit at least 2 to 3 months before they are discharged in the community. So it takes them that long to get used to somebody, to form a relationship with somebody. And then they kind of tend to work better with these people. And that is when they are more likely to go for their appointments. That is when they're more likely to trust somebody. So that's probably something to look at. I don't know whether it will help or not, but we have tried it and it's been more helpful. And then you can also look at whether it's a good fit or not. Sometimes these youth are not comfortable with females, sometimes they're not comfortable with males. They have strange ideas about why is it that we are not going to be comfortable with this guy. And it's true for us as well. Leave aside somebody who's got some kind of neurological impairment. We pick and choose the people that we feel comfortable with. We just don't go out randomly with anybody and everybody. More so if this person is being forced onto us as part of some kind of healthcare or child and family services agency or anybody at all. So they don't see it necessarily as a friend. And the important thing is knowing that person first, being able to trust, then only can they go out and do some activities.
Would you like to answer some more questions now
Yes,
or later?
yeah,
Okay.
yeah.
I have a couple questions from Deb in Prince Albert. She asks first, is it appropriate to restrict access of youth to parents with addictions? And if so, what type of interaction would be helpful to retain contact with a parent?
I think it's difficult to answer a question like that without having a lot more background information. Obviously, if there are ongoing concerns regarding parents using alcohol and drugs, then there do need to be some restrictions. But at the same time, I cannot necessarily say, yes, we need to restrict that contact. If it can be supervised contact, which is appropriate, where the parents can or are able to attend these visits without being under the effect of alcohol or drugs, are not inappropriate in their interactions with the youth, it is always advisable and beneficial to have that contact. On the other hand, if there are ongoing concerns about the parents being under the effect of alcohol or drugs during the visits, they are inappropriate in their interactions with the youth, or the youth becomes really upset following the visits, then one has to reconsider whether the contact should continue or not.
Deb also asks, have you found that these youth can be helped by grief and loss counseling?
Definitely, if they have experienced anything like that. And what we need to remember is grief and loss is not just about death of somebody in the family or friend. Grief and loss for them is also about the fact that they may have been removed from their family. That in itself is a huge loss. They may have lost contact with a long-term carer or a foster carer. That's a huge loss as well. So what we need to remember is grief and loss is not just about losing somebody as a result of death. It could also be a result of people moving around. So if the youth is moved out of their environment, we had a question from a foster mother who has had this youth for 6 years. If for whatever reason this youth was to move out of that family now, that would be a huge loss. So he would definitely be helped, and I won't be surprised if he has a significant deterioration in his presentation. So yes, definitely.
We'll ask one more question now, but people can keep sending them in and we can ask or answer more questions later. Diane also asks, she says that we have many youth that live in unhealthy homes with no other options at this time. Is it possible for that youth to behave appropriately in a supported school environment, even though at the end of each day they return to an unsupported home?
Yes, why not? And that's where when my first slide was about environment, it is quite possible that if the youth is in a safe environment where they feel that people do care for them or do care about them, they are likely to respond in an appropriate manner. While if they are then going back to a family environment where either the parents are intoxicated or are using drugs and alcohol all the time, have issues around aggression, are absent, then obviously the behavioral difficulties can increase. And it's a clear evidence that environment is having a clear impact on the interactions of the youth or on the behaviors of the youth. And these are the issues that carers may not always be aware of. So how to ensure, say for example, whether somebody can go out with somebody or not, whether the behavior seems to be appropriate in one environment but not in the other, then we need to find out what's going on in that environment. It's not necessarily because the youth is trying to be manipulative in that environment. There is probably something that is upsetting the youth, that is making them angry or tearful or harming themselves or whatever it is. Quite a few people with FASD do present with symptoms similar to ADHD. And again, we need to be aware of that. The staff or the carers or the parents, they need to be made aware that they may not necessarily be able to stop and think before acting. So they will need help around that as well. Number of these youth present with sleep difficulties. We know now from various research that quite a few people, normal people, without any neurological impairment can present with delayed onset sleep cycle. So there are people who do not go off to sleep or who feel okay to be up till 12, 1 o'clock at night, but then they have difficulty starting their day early in the morning. So they are usually much more active after 8 or 9, something like that. While there are others who can easily go off to sleep at 9 and be up at 4 or 5 in the morning. So people have different sleep-wake cycles. And youth with FASD can have significant problems with sleep. And again, part of the reason is if they have moved through several placements, if they have been around 20 different placements in the last year, not uncommon that they move around from one motel room to another with one FASD worker or a youth worker or a child and family worker. So they are sleeping in a different bed every day or every week. They are sleeping in a different location every week. So it's not easy to go off to sleep then. And obviously, as I said earlier, they have difficulties with expression and comprehension, which was very evident from the example that I gave about our youth. So he had some memory problems, but at the same time, he also had difficulties understanding what was being explained to him. So it's not uncommon for these youths to come across as, yes, I know what you're talking about, but then you tell them to repeat what was said. They won't be able to repeat it. So they are very street smart. They can survive on the streets, but they don't necessarily understand the language that we are using. They don't have that complex background or complex ability to understand the language that is used in our circles. So that's another thing that we need to be aware of. So one of the things that we did, and in fact I'm probably going to discuss it in one of the later slides if we do manage to go through them now, is this same youth that we discharged recently who had been charged with several stabbings. He had several conditions attached to his community order. And there is no way he would have made sense of any of that. It's complex legal language. How many of us can understand that? So what we decided to do was just make it simple. So there were 5 conditions or 6 conditions. So make it simple. You cannot have guns or knives or bear mace. So you actually, when it says he's not allowed to possess any weapons for the next 5 years, he might see a weapon as a gun or a knife, and that's it. He doesn't understand a bear mace is a weapon as well. Or he doesn't understand if he's carrying a screwdriver, that is a weapon as well, unless it's related to his job. So he doesn't understand those things. So you literally have to try and identify those things, simplify it. So what we have done is, for him, is on his wall, in big letters, all it says is his conditions in simple language. So go and see your probation officer at 5 o'clock every day or every Tuesday or whatever it is. Because the condition from the court says, see your probation officer as directed to. So he has no clue what does that mean. What do you mean by directed to? So try and fix appointments the same time, the same day every week. Try not to change it. Consistency. They will forget. They don't have the network in place in their brain that can retain that information and then organize their schedule accordingly. So if they have to go and see addictions counselor, it is best to see the addictions counselor on the same day, same time, every week. So those are the important things. And those are the things that people working with them need to understand. So if you go and see the probation officer at 5 today, which is Wednesday at 5 o'clock, and then say, okay, next week we'll see you at 3 o'clock on Tuesday, he's likely to forget. He's not going to remember. He doesn't carry a diary like us. He doesn't carry an iPhone or a BlackBerry to note it down. So those are the important things to understand. Obviously, most of these kids present with huge issues around education may have specific learning difficulties, may have global learning difficulties, but with support, with appropriate environment, they can do wonders. One of our youth who I mentioned earlier, who was charged with a murder, absolutely no inclination to go to school. There's no way I'm going to school. I don't like it. I'm not doing it. And that's where his behavior was quite kind of a good example of how do some of these youths think. And then suddenly, one of the family members, an uncle who was not even a blood related, who has been involved in his care, we started having family therapy, who was willing to look after him even after his discharge, comes in and says, look, you see, this is how I work. He's a pipe fitter somewhere up north. So this is the education you need to do for that. And if you manage to do that, then I can get you a job where I work. And that's it. From that day, that youth still continues to get into trouble. But school is one thing he's never missed. He just goes back. Nothing has changed. The only other thing that has changed is he's currently in an institutional setting. So the help he's getting there is very different from what he might have got in the community. This other youth who has been charged with several stabbings, he came to us with, I think, about 40 credits. In just over 12 months, he managed to get another 50 credits. So he had 40 credits over 16 years of his life, and then in about 13 to 14 months, he managed to get another 50 credits. So he's likely to complete high school in the next 6 months. So it's easy to get away by saying they do not have the abilities. But on the other hand, if we can provide the right environment, if we can provide the right kind of support, they can still achieve things which can help them to have some kind of a job. They don't have physical disabilities. We need to remember that. They only have some neurological problems that impede them from organizing things, from doing things in a certain manner. But they can still do stuff around manual labor. They can still do some of the jobs under supervised conditions. So it's about identifying them. So within the school system, it's about identifying their deficits, coding them accordingly. One of the things we do at the hospital is obviously we have very small classroom sizes. We have one teacher to every, I think, 3 or 4 kids at a time. Shorter duration of teaching, basically. They're usually, I think in any go, they don't stay in one classroom for longer than 45 minutes, which is probably normal as well. But for some of the kids, we reduce it to 20 minutes, 25 minutes. And every 45 minutes, they have a break for 2, 3 minutes, 5 minutes. And as I've mentioned earlier as well, ensuring their understanding of the concept. They might come across as somebody who has understood whatever is being said. Always, always ask them to repeat what has been said or taught. That is when you find out suddenly, oh, it looked like you understood everything, but you probably haven't got more than 25% of it. And that is not unusual. The greater difficulties are with comprehension. Their expression is still very good. Or, I won't say very good, but comparatively good. Better than comprehension. And as I said earlier, that if they have been kicked out of school, or if they're running away from school, it's not necessarily because they have behavioral difficulties, because they are running out or truanting to use drugs. But it could possibly be because either they are being bullied at school, or they don't understand what is being taught at school. So they are getting bored. They have no clue what is being said there, but the expectation is that they have to reproduce or produce some work that is being taught to them. So it's important to try and address those issues rather than just saying, no, you have to go back to school. You don't have a choice. So try and find out the reasons. Why is it that they are not going? Why is it that they are running away? And as I mentioned, sleep difficulties. Environment is again an important factor. They have to be in a place where they feel safe to go off to sleep. They don't have to worry about being jumped upon. Do not use it as a place of punishment. So their room should not be the timeout room or a seclusion room or a restraint room. And I must admit, we do the same thing. We have limited number of rooms. We do that for quite a few of our kids. So if they have been in trouble, if they're getting aggressive, we send them back to their rooms where they're also expected to go off to sleep then. So it's always better to identify one room that can be used as a seclusion room or timeout room in the entire facility, and then leave the rest of the rooms as a place of safety, as a place where they go off to sleep. No bright lights. Yes, pictures are good, but not too many. They get stimulated easily, very easily. So those are the things that one needs to remember. And if needed, use medication. I use melatonin a lot. It's off the counter, does help, low dose, minimal side effects, nothing wrong. And if they persist, then probably you can get a referral to a specialist sleep clinic. I think there is this, I forget the name of the physician who runs a sleep clinic specifically for youth. It will probably come back to me. I've already spoken a lot about relationships. We had a couple of questions about boundaries and relationships. And it is an integral part of whatever planning, whatever treatment, whatever therapy we're trying to offer. If these youth cannot form a proper relationship, nothing is going to work. And you could see extremes. You could see youth who are actually completely isolated, do not want to interact with anybody, like the 17-year-old we were just talking about, who doesn't want to go out and talk to anybody. On the other extreme, we get people who just want to talk. It's almost to the level of being disinhibited, because they need that reassurance all the time. They need people to tell them, yeah, it's okay, what you're doing is fine. So we had this another youth who had about 20 different people on his contact list. Only about 2 or 3 were family members. Rest of them were all professionals. So he had a probation worker, he had a youth worker, he had somebody from McDaniel Project, he had somebody from McMahon, he had a child and family support worker, he had somebody from Youth Criminal Defense Office, his lawyer, his previous foster carer. And during the day, he would actually start calling them one by one and just call everybody. By the end of the day, he would have called everybody until and unless he had managed to speak to at least 2 or 3 of them. So he was so dependent, he needed to talk to people. And even on the unit, if he couldn't find anybody to talk to over the phone, he would go to various offices, staff offices, just stand there on the door and talk to them. And that is what some of them do, because they are so dependent. They feel so kind of neglected that they have this need to talk to everyone. So we don't necessarily always find youth who don't trust people, who don't want to talk to anybody. On the other hand, we find people who want to talk to everybody. But that's where it's important to make them understand what are boundaries, what are appropriate behaviors. And if we cannot identify one or two key workers, then it is going to be very difficult to help them open up, to talk about the various traumas and abuse that they have suffered over the number of years. Work around a crisis plan with them. So if they are in the community, if they are going to get into trouble, or if they are in trouble, who do they call? Most of us work 9 to 5. Then what after that? Most of these youth get into trouble after 5 o'clock. It's around 9, 10 at night that they start getting into trouble. So what do they do then? So one of the things we worked out with one of our youth was to give him some phone numbers. So his probation officer would be gone by 5 o'clock, but the attendance center is still open till about 11, 12. So just call the number there and just say, I need an out. And inform the probation officer that this is what is a potential situation. So if that happens, if he calls, then what needs to be done? So if the friends are insisting, no, let's go out, get a drink. No, I have to go. Where do you have to go? Go see my probation officer. But the probation officer is gone now. They want me to come to the attendance center. Come on, you're telling a lie. No, I can call them, see? Because they don't have the ability to come up with a plan in situations of crisis. And they would not be able to follow that plan if you have just written it down on the paper and given it to them. You actually have to enact it with the youth. Role plays, repeated role plays of the crisis situations. We have actually brought in empty bottles of alcohol on the unit just to do role plays. We will go around, sit down and offer drinks with bottles of alcohol filled with water, filled with tea, trying to give it the same color. The difference in their expression, in their interaction is amazing when you create those real life situations. And that is what needs to be done. So you cannot teach them boundaries by just saying you're not supposed to touch anybody. What we literally do on the unit is somebody walks too close. Okay, this is what we need to do. Go stay at least this far off. So whenever you're walking to somebody trying to talk to them, make sure that you stretch your arm and you're at least that far off, so you're not invading the personal space. And you'll have to do it repeatedly. Believe me, you may have to do it 50 times, 100 times, and it may still not work. Repetition is very important. Role playing is very important. They are looking for acceptance. They don't know what is right or what is wrong. According to them, sometimes hitting is part of being accepted. Using drugs is sometimes part of being accepted. So you really have to work around all those things. And as I mentioned, impulsivity, hyperactivity, ADHD, issues around ADHD are not uncommon. So they do present with a number of those issues. So behavioral intervention, if possible. If not, then we have to use stimulant or non-stimulant medication. I'm probably going to kind of go a bit quicker through the rest of the slides because I'm kind of aware of time. Are there any more questions?
We have one from Dee Dee in Mara, BC. She is another foster parent. She says, I have had my child for 6 years. She is being reunified into the reservation to be with her mother, who she has not been with for 8 years. There was extreme trauma for the first 3 years of her life that she remembers. What suggestions would you make for the reuniting of the mother and daughter, even though mom has only been clean a year and has an 8-year-old boy starting to visit, and a 2-year-old girl who she sees weekly, and a 1-year-old boy who is extremely needy? It is believed all the children have FASD.
See, and that's where, when I started by saying it is not something that can be done by one agency. So what we are looking here is, what's the role of mental health services? What's the role of child and family services? What's the role of, I don't know whether mom herself has mental illness as well or not, on top of addiction issues. The environment that the kids are going back to, is it the same home where they were abused? Is it a different place? If you are sending them back to the same home, despite the fact that the abuse is not taking place, it's going to really bring back some memories. So, and all those things need to be looked at. It's difficult for me to say what should be the plan, but what needs to be done really is that all the people who are involved, all the agencies who are involved with this family actually need to get together, sit down, and then formulate a plan. It is not going to help if, as foster mother, she's trying to do something just with the child welfare worker of this girl. It has to be a joint plan which has to be implemented with all the child and family workers who are looking after all these 4 kids. If mother herself has an addictions counselor or a mental health worker, somebody has to look at the placement where they are going to visit her. The kids themselves need individual therapists. There need to be family therapy put in place. The person who's supervising the visit, family visit, should not be somebody who's just sitting there and reading a book, who has no clue what to look for. It should be somebody who's trained to see what kind of interactions is the mother having with the child. How is the child responding to the mother? What is it that needs to be addressed in family therapy? Because somebody could just sit there and just make sure, oh, mom is not abusing the kid, and that's it. But it has to be more than that. It has to be, is it a good quality interaction? Is the child scared of the mom? Are they actually having appropriate physical contact or not? Are they having good non-verbal communication or not? And those are the things that everybody needs to get together, sit down, and then come up with a plan. There also needs to be a long-term plan. Is the plan for the kid to actually go back to the mom? Then it has to be done differently from, no, the kid will not go back to mom ever, but would stay in wherever they are, but have contact with the mom. So you're kind of planning changes based on that, whether the expectation is at some stage the kid is going to go back to the mom or not going to go back to the mom. So what is it that would be the expectations from the mother before the child can go back to mom? And what is the role of education? Is the child doing very well in school right now? How is change of school going to affect? Is the child then going to go downhill quite seriously? So all those things need to be looked at. And I cannot really say what is the best way of doing it, but all I can say is everybody needs to get together and look at all those issues. I have earlier mentioned a lot of these youth present with mental health issues. So obviously one needs to be aware of issues around depression, self-harm, psychosis, ADHD, as I've mentioned, and they need to be treated appropriately. Again, what we can't do is not treat the mental illness, but try and do rest of the stuff. Or treat the mental illness, not change the environment. As I have earlier mentioned, we were doing that with that girl. But unfortunately, that's where, if we cannot work together as various agencies, then providing that treatment for mental health issues is not going to help if she keeps on going back to the same environment. Social interactions, we have probably gone through them at great length in the previous slides. Relapse prevention plan. Again, it's about having various crisis plans, role plays, looking at what led to the actual offense or the incidents that they have been involved in. How can they be prevented? So if we keep a youth on our unit for 18 months, 2 years, and then send them out after that, we have done everything, it's not going to be helpful unless they have a job, unless they have some way of making some money. Because the only trade otherwise they know is when they go out is either selling drugs or stealing or robbing somebody. So occupational training, vocational placement, they are all important parts of relapse prevention. Practical steps, as I was mentioning, have crisis contact numbers, have alarm for appointments. If possible, give them a simple phone that all the appointments can be fed into and have alarm set on for it. Provide escape route, like the example I was giving about calling the probation office. A readily available calendar on the phone. So those kind of things are important. And again, practical support. Set up appointments. Do not expect them to set up the appointments. Try and keep them on the same day, same time. Visual reminders of probation appointments. So again, these are all the things that we have gone through. So I'm going to skip through this. Criminal justice system, again, we have discussed quite a few of these things that they may not be able to comprehend what is being said, especially when they're on the stand, if they're in court. I've been going to court for about 10 years now, I think, and I still have difficulty on occasions understanding what is being said there. I'm not a lawyer, but I'm a well-trained professional, well-educated professional, and despite that, I have problems. Imagine these people. They won't be able to understand what is said. Sometimes they would plead guilty just because they're just fed up of being in the stand there or going back to court again and again and again. Let's just plead guilty. That way it will be over with. So try and understand why is it that they're saying they will plead guilty or not guilty. Ask them. Discuss the reasons for entering a plea. Sentencing. Usually the way our criminal justice system works is you're charged with an offense today, but by the time you're sentenced, it's already been 18 months. These people can't even remember things that were done yesterday. So it's not going to have any effect on them. It's not going to change what has been going on. They won't remember what was done. They won't remember what were the charges. So extrajudicial sanctions, healing circles, they are very important things. Try and consider those. They're a much quicker way of dealing with it, not necessarily punitive, and might be more helpful. I was talking about some of these things that they do some of these behaviors because of their neurological deficits, not necessarily because they are being manipulative, not necessarily because they are being stubborn. So non-compliance is not willful misconduct, but it's because they forget, because they don't remember what has been done. So there are some examples that I've taken from actually criminal justice website and also a resource guide for teachers. So you can have a look at that website if you want. I found that quite helpful, just to put some behaviors in context of the cognitive deficits that they have. And as I said, adapt the environment. Verify their story. Don't assume that what you see is indifference or manipulation. So it's again about their being able to understand their neurological and cognitive deficits. Use a lot of repetition, role plays. And as I said, multiple agencies. Can't do it in isolation at all. There's no way to do it in isolation. It's never going to work. And that's my last slide. So it's open for discussion, questions.
I'm just wondering if anybody in the room has questions.
Yes.
I was wondering if you are working in a situation like the criminal justice system, how can you increase consistency if youth are going in and out and staff members are going in and out?
Okay.
And can you repeat the question?
Yes, the question is, when you're working in criminal justice system, how can you ensure consistency if youth are going in and out as well as staff are changing as well? It's interesting that you asked that question. Actually, recently, I obviously deal with a lot of lawyers and a lot of people in criminal justice system. The criminal justice system itself, especially in Edmonton, I'm aware, are trying to make some changes. And one of the things that they are trying to do is allocate a single lawyer, whether that's a Crown or a defense lawyer, to a youth who has been known to engage with criminal justice system repeatedly. So that's kind of part of consistency. So what they're trying to do is have the same Crown prosecutor or have the same defense lawyer who will be dealing with one file. So not necessarily saying, okay, from legal aid, this is the lawyer available today, so you pick this lawyer. So what they are trying to do is identify the same lawyer. And I'm aware that the Youth Criminal Defense Office is actually currently doing that for some of the youth that we deal with. So if they are coming back to the system repeatedly, they end up dealing with the same lawyer. Similarly, some of the other things that are being discussed is whether the same judge over a period of time can deal with the same youth, so that gives some consistency as well. The other thing that has recently been implemented from Alberta Health Services is a youth diversion scheme. And I'm not sure if people are familiar with that or not, but it's a way of almost looking at extrajudicial sanctions, but through health services with a joint venture with criminal justice system. So the staff members may not be consistent there, but hopefully the services that are being provided there might provide some consistency.
Any other questions in the room? Okay, we'll probably wrap up for now. I can just read this one comment from Sarah. She says she wants to express her deep appreciation for this fantastic presentation. It was meaningful and helpful. So thank you very much.
Thank you.
I want to reiterate what the person online said, and thank you very much for a great presentation. I will remember critical factors or consistency and environment and all the issues around that, and the importance for education and training across the spectrum, and also how important collaboration is. It becomes more and more evident that we can't do this with just one person. I want you to remember that evaluations will be emailed to you within the next 2 business days, so please be sure that everyone signs the attendance sheet. Your feedback on this session is very important to us. Please join us for our next presentation on December the 12th. Dr. Jacqueline Pye will be presenting on developments in FASD research. Thank you very much.